Putting the mouth back in the body is a marginally pompous title for a presentation, but it's something we've been trying to do in oral health for a number of years, and I think this meeting here today is an example how progress is being made. It's terrific to have the Skills Council interested and involved in our topics. This whole issue gained momentum, I think, quite significant momentum with the adoption of the National Oral Health Plan in 2004 by the Australian Health Ministers Conference with some vigour. It was delightful to see. I do remember a senior health bureaucrat in one of the states, when he saw the National Oral Health Plan, said it was either complete incompetence or a conspiracy, because there were so many things that needed doing, and he felt that this was a dangerous document. Well, in the years since then, it's proved an extraordinarily useful document in terms of guiding directions for oral health. And I think just a moment or two on the structure of the Oral Health Plan. It focused its national actions on a bundle of key action areas: whole population issues, children and adolescents, older people, low income and disadvantaged, as you see, people with special needs, Aboriginal and Torres Strait Islanders, and then workforce. Not a surprising list, useful list in terms of the database on oral health needs and actions, interventions that might work. I found an interesting thing when preparing for today, that there were 49 national actions, which is a pretty full book. 15 of these actions relate to increase the oral health capacity of the non-dental workforce, and 5 deal with actions relating to the dental workforce. I think that was a sign that even then, in 2004, there was an emerging appreciation that to improve oral health in the community, it wasn't just an issue for the dental sector to deal with. Dentistry has a tradition of setting itself up separately and running its own show and ignoring the rest of the world. And this was the first sign that the world was changing. Now, the actions to do with the dental workforce, there has been progress on. In fact, there's been progress on many of those 49 actions with surprisingly little money, but significant progress. There's many more dental providers being trained. There are more dentists, more dental therapists, oral health therapists, hygienists being trained. There's progress in terms of better use of the entire dental team in addressing problems, and that's pleasing to see. But then the 15 issues to do with increasing the capacity, competencies, the language I'm learning about, of the non-dental workforce in our area, dealt with these things. This is extracted, these words aren't in the plan, they're extracted from those 15 national actions for increasing workforce capability in the non-dental workforce area. Oral health promotion modules for non-dental people who are involved in service delivery, health promotion. Simple oral health screening and assessment tools. Having non-dental people get involved in the process of seeing these people, because many of the rest of the workforce see the community far more often, far more frequently, far more of the community than the dental team does. Care planning. Care planning is a broad church, but it includes identifying the broad things that need doing and referring when necessary. Assisting people maintain their oral hygiene, people who have difficulty or need assistance doing so, and then referral, of course. I'd like to say also, particularly, I'll refer passingly, with very few statistics and very few numbers, but passingly to a number of outcomes of evaluation along the way. And in the projects I'll talk about, they were done in partnership with the Australian Research Centre for Population Oral Health from the Adelaide University, John Spencer's team, and it has been integral to the designing, planning and evaluation of these processes, and led us to understand what things were and weren't working. I'm going to start with one of our projects that dealt in this area, that built on the actions of the National Oral Health Plan, and that was the issue of children. And this graph is simply the general anaesthetics for dental caries for children in Australia. And the trend is a little obvious, so it doesn't need describing and pointing out there, that there's been a significant increase in the number of children having general anaesthetics for dental caries in Australia. And now it's one of the most common reasons children end up with a general anaesthetic. Now clearly there's an issue there. The National Oral Health Plan recognised there was an issue, and there are interventions that needed implementing to begin to get on top of this problem. And so started a project, and the key element of this design process was to get together other people who were involved in this problem other than just the dental sector. So it was maternal nurses, maternal and child nurses, it was GP divisions, it was paediatric specialists, and it was primary care services like our school dental program. And what we wanted to do was to say, well look, this problem has arisen because parents weren't aware of the things that they were doing that were contributing to this problem. Children were developing early, rampant, aggressive decay, as early childhood caries is, and it wasn't being recognised early. By goodness knows how many people had seen that child in the preschool years until it got to a significantly severe stage. And so there wasn't an opportunity to intervene early to address the problem at a kind of secondary prevention stage. And then treatment pathways weren't always there. So if we were going to go on top of this issue, the National Oral Health Plan pointed to these areas as needing work. So the Population Oral Health Project involved GPs, nurses, childcare workers and other healthcare professionals who are ideally placed to deal with this age group, far more than this relatively small proportion of children that see a dental team at this stage. We'd like more, obviously. And so this is the result. And this is an extraordinarily rapidly progressing dental decay in young children. Oh, and look where it starts, almost universally, right at the front teeth where you can see it easy. So the Lift the Lip project commenced, and in collaboration with those other workers, a process was designed to assist other healthcare workers, other service delivery providers, to identify this problem early and understand what to do about it when they find it, in terms of information, in terms of referral pathways. Now, this is kind of something of an extract from some of the documentation that we provided, and perhaps the middle one is the one to look at, so I've blown it up a little bit. It starts as little white lines on the front teeth. Lift the lip, 3 seconds, have a look, there it is. And those teeth could be scarcely there in a relatively short time unless there's an intervention. A referral pathway was designed in collaboration with these people, built into the GP system. Often it was practice nurses and the like that were doing this work, but built into the GP system, and maternal and childcare nurses with our Children, Youth and Women's Health Service, so that there was an easy way of saying, here's the problem, I know what to do about it, and there's an easy way of smoothing the pathway to the interventions that are necessary, preventive interventions to stop this progression. In the period since this program started, a couple of years back, a little less, a series of education evenings have been designed for divisions of GPs and their nurses. Over 200 child maternal nurses from our program in South Australia have been trained. Further training's taken place, moving into training into the areas that are smaller in size but important in need, like the Aboriginal healthcare worker environment. A massive effort in terms of training, together with these supportive packages. So the referrals are coming. 1,500 so far of children, mostly 4 years old, too old. That's because the system finds it easier at the current stage to see the 4-year-olds, but that may change with the change in the age at which children are being screened by the maternal and childcare nurses. Mostly the nurses are doing the referring, most of the GPs and their practice nurses aren't yet, so there's a learning lesson there. These children have twice as much decay as the rest of the child population in that age group, so in general terms it's the right children being identified, and we've got double the rate of referral for the Aboriginal children, so we're beginning to make progress in that area. And so those children get to the stage where they have the opportunity at an early stage in the decay process to have clinical interventions applied, fluoride and the like, and to stop that progressing to the stage where it needs more aggressive interventions such as general anaesthetic and treatment in hospital. So the lift-the-lip process is quick and simple. It builds on existing systems that are already there looking after people's health and well-being. Didn't create an entire new system. It said there's a system out there that is looking for the health of people, and it's adding a bit into it. And it is simple to do, and it is supported by referral pathways. And the process seems to be working successfully. It's a process, though. Any change in this environment takes time to work through the system.